Thank you for the audience still remain in tune with us. I have one announcement here. After my session and after Professor Low's presentation later, we will have today's group photo. Just like yesterday, please show your face in Zoom, and we can collect all the face in front of our screen, and probably have the 5 to 10 time of a group photo. And later on, our technical team will build up completely the whole attendance participations, the group photo, and we'll send back to you. Thank you for your cooperations. My topic is to talk about imaging applications in Cleft patient. The first slide is to talk about the protocol in Chang'an craniofacial teams to treat Cleft babies since he was born till she turned to as an adult. So this is the timeline for the treatments. So since the newborn, 3 months of old, 9 months of old, 9 years of old, and the age, and until around 17 years old, and later on the final, probably in all the bone tissue maturation, you can see from this slide. All the baby received is not only for a single or only a one or two surgeon or orthodontics. It included all a kind of multidiscipline team members, including the psychosocial therapist, psychologist, speech therapist, and so on, ENT doctors. So the baby turned not only in the external appearance, and as well as in the bony maturation as well. And this is the protocol in our center to deliver, just be mentioned by Professor Low, from the different time of age, and we can give a different treatment of our goal, and to turn for the baby for a better aesthetic outcomes. So, what is the image should be delivered to the baby with the cleft? It depending on what kind of surgical procedure or what kind of orthodontic treatment which will be delivered. So we have to know what is our purpose and what is our target. So we have to know the first one is the growth patterns. Maybe the baby was in just within the 1 year of age, or the baby is waiting for a Protoplasty, and even when he grow up and waiting for alveolar bone grafting. Different procedure, and we need a different image study to analyze the bony situations. So later we have differentiate. We want to change is the hard tissue, or we want to change is the soft tissue. The last one is the different surgical reconstruction, what we want to give. In the first, lip repair is the first surgical treatment for the cleft lip babies. So the complaint, I think, it's always come from the parents. I think all the parents want their babies, the cleft lip could have a very wonderful repair, and maybe the depressed nose can be corrected at the primary rhinoplasty at the first time. So the target is the lip repair in the nose. So I think in the first image it should be a two-dimensional photo. It's only like this. Maybe we cannot look at inside of the bone, what the bone situation happening. So the surgical boundary is only focused on the soft tissue. Yes. However, sometimes in the past, some surgeon maybe will do the computed the tomography and to look inside, oh, how much is the bone defect inside. So we can get some information from the CT as well. But at this time, it only can provide it very seldom, very last information for us, because we do not change any bone condition at these times. And next, when the baby was grows into the receiving the protoplasty time, so I think the same, the patient or the parents will complain the baby has the cleft palate, and maybe cannot swallowing or eat the food very smoothly. So the target is to treat the palatal side and to treat the nasal side without any connections. So the target is to prevent the happening of the oral nasal fistula. So the surgical boundary, I think, is only focused the soft tissue as well. So this is the figure to show our standard protocol. the standard figure, the final finish of the protoplasty. And when the kids grow into the school age, is around 9 to 11 years of old. At this time, I think all the kids is already have no more very big or very dramatic the facial appearance, the deformity. So at this time, just I have mentioned in the alveolar bone grafting, all the alveolar defects should be repaired or be filled with the adequate bone graft or some the scapa fascia to prevent the connection in between the nose and the mouth. So we have considered the following images should be delivered to check and to analyze pre-operatively to know how is the adequate volume to support in the alveolar defect. So as the bony defect, we can have the X-ray or the combing CT. And for the external facial appearance, we can check with the 2D photo as well. If you have a kind of advancement modality to see the image difference, you can apply a 3D dimensional, like a 3D MD image, to check more in detail in different multifaceted vision to know, okay, before and after, to look at the successful or the change of the surgery. So when we deliver a kind of a bony material checking, we have to consider some factors. The first one is the bony defect, and then is the bony volumes, and next is it very expensive or not? I think in some certain countries, I think the combing CT is not always available for a baby to receive in the alveolar bone grafting. And actually, in the clinical practice, the combing CT is not really very necessary for this kind of study. And then you have maybe to consider the radiation dose. Is the radiation dose is too high, or the radiation dose is acceptable for this kind of preliminary study? The next is to look at the external facial appearance. So you can check currently how is the defect in between the lip and nose. And then we can check the mid-face fullness. And I think the 2D photo is only give you very limited resource, and only you can select maybe the only one side or one vector, look at very limited information. And if the 3D you can get, you can obtain this kind of modality, you can have more full information. However, it's really very expensive. It's not really can be available in some certain area or some hospital. However, either the 2D photos or the 3D MD photos, they all provided the non-radiation material and the information to you. Okay, so the first one is the X-ray. As I already mentioned, is the X-ray can deliver as a good guideline or a reference for the surgeon to know is the bone grafting surgery is the successful or not, because we can determine the bony volumes in the cleft side. This is pre-op, this is the post-op. So easily you can check, okay, the bone is formed and the bone is survived after the procedure in the X-ray. So in our hospital, I think just I already mentioned that without the fascia graft and with the fascia graft, the successful rate is different, much different, with the significant differences around the 60% versus the 90%. The next one, this is the 3D MD photograph, and you can look at the different side of the girls. This is a typical unilateral cleft lip and palate. Before the alveolar bone grafting and after alveolar bone grafting. Using the 3D MD modality image, you can easily to differentiate it, how is the mid-face fullness is obtained or not. Because in our research target, I think the alveolar bone graft is not only can fully surface all the bony edge or resurface in the bone boundary, as well as after the surgery, I think all the patients can have a better mid-face fullness as well. And in this material or in this modality, not only can only focus in one visions, you can turn around any different vision to know and to analyze how is the facial ratio and the facial length and how to know the bilateral symmetric or not in this kind of modality. And take another example in this 3D-MD as well, pre-op and post-oply. The 3D-MD is very friendly, non-invasive, no radiation dose, or however, it's really very expensive. However, but for a research or for to audit how is your surgery is good or not, this is a very good imaging modality. Later on, maybe in your hospital can get a good combined CT as well. In our craniofacial center, for some patients receiving the alveolar bone grafting, we can routinely to obtain the pre-op and the post-op, the combined CT, and we can keep and going to see how is the bone growth afterward. So you can easily to see in the two different timeline of the bone. This is a pre-op. I'm sorry. This is the pre-op. So I can see over the right side there is the bony defect, and after the surgery, the right side of the bone defect is already be repaired and augmented. So I think there is one of the questions audience has mentioned about why we have to dissect to the anterior nasal spine when we do the alveolar bone grafting. It's because if we reach to the anterior nasal spine, I think the space can be easily to be seen, and I think the tissue, the soft tissue, could be loose easily and can facilitate the later on the soft tissue repair. And of course, in our study here, we always to measure what is the volume in this the cleft alveolar defect. The anterior nasal spine is one of our boundary as well. This is the second case, and we can view the different timeline of the surgical AVG before and after. So before, you know, there's a defect of the left side. After the surgery, all the boundary of the original alveolar defect is be fully well formed of the bone density and the quality. So one question I think that in the alveolar sections, that one audience has these questions. How is the adequate volume we need to augment in maybe the unilateral side or the bilateral side of the cleft patients? We have conduct one RCTs or is a prospective study. We using the combined CT, and we can print it all the model of the alveolar cleft defect model, and we can measure it using the party to know what is the volume. And the other side, we can use in the combined CT and using the software. For example, what we using is the simple one, and to measure what is the real defect inside. So over the right figure is to tell us how is the real volumes in the unilateral patient and the bilateral patient. The blue dot is to talking to us for a single unilateral cleft, the volume needed is around 1 milliliters, and the most is the 1.5 milliliter. And for the bilateral cleft alveolar defect patients, what we measure is around 2 millimeter, and up to the most is 2.5 milliliters. So according to this, the literature suggestion is that maybe in the future, how much the volume you want to harvest the bone graft is around at most the 1.5 milliliter for unilateral cases, and the most is 2.5 milliliter for bilateral cases. But is could reflect to in your hospital or in your patient, it depends. Because in our protocols, I think the all the lip repair and I think the palatal repair is based on our protocol here. So when the patient receiving the alveolar bone graft, all the defect is already be shortened and be decreased in the very limited the bone defect. So this is our data. So what we using the simulation to measure alveolar bone defect. Okay. I have a small video we can check, very quick video. So we using the convenient city as our baseline, and we post it into the Simplant software. And the target is we want to measure what is the real volumes for a unilateral cleft lip and palate. So the first step is to segment all the unrelated the tissue and to remove the excessive tissue in our photos. And based on our boundary of the alveolar bone graft, anterior side, bilateral side, posterior side, superior and inferior side. And this is our model. So you can see in the model have some different color of a party because we're using the party to put on the defect, and then we measure how is the volume it is. And then we come back to the Simplant software. Okay, then is the manual sculpture. Just as the surgeon perform the filling of the bone grafting, and you can cut all the space not inside of the pocket, not inside the alveolar defect. This is the posterior side, and we remove it. And the superior side, we connect it into the lateral side and the anterior nasal spine, and we're using the boiling operation, and finally calculated is the real volumes. And then the volume is around 1.2 milliliters. So around 40 cases, we can do this kind of measurement. Okay, so you can see 1.13 or 1.6 milliliter is needed in these volumes. Okay, so this is one way we're using the images, the software to do the calculation of the analysis in the research. And later, we are going to, if the patient is needed for the orthodontic surgery later on, I think the patient, just like the Dr. Yao and the Dr. Kerr, Dr. Liao, just as mentioned, I think we have to meet the demand of all the patients, even their parents. What is the real complaint for the orthodontic surgery in the cleft patient? The first one is the mid-face, the retrusion. The second one is the prognathism. And third one is to correct the malocclusion, angle class 3. So the target is to do is the malocclusion correction. And the second is all the patient want the facial profile harmonized. So in this kind of surgical procedures, the boundary is not only in the hard tissue, and we have the emphasis on the soft tissue change as well. So as the Professor Yao already delivered in his speech, he using the virtual planning and to preoperatively do a lot of measurement and to know what is the demand from the patients. So we have to change the maxilla and change the mandible as well to do a maxillomandibular complex rotation to achieve a better facial outcomes. In our already published paper, this is talking about the skeletal reconstruction of the cleft-related deformity. We divided it into the 3 different timelines. The first line we call it, and we focus on occlusion center face. The second is the facial center face. And recently, the 10 years, we focus on the patient center face. In the first 10 years, the occlusion is our key point. Maybe we are only to emphasize on the occlusion only. Later on, we can listen to the request of the patient. They are looking for more and more on the facial appearance. And later on is the patient-centered one. So in the conventional way, our orthodontic doctor and the surgeons, they will design and plan based on the 2D cephalometrics and do the paper surgery as well. And they will make up like a model translation, and they can do in adequate the occlusal plane, and they can rotate it the MMC in their manual translations. By this way, we can design a splinting, and for our final determination of occlusal status, and we can, as a surgeon, we can do a little bit different change to achieve a good result. And recently, we proceed and advance it to a 3D design, and we can design in the software and based on a preoperatively the compensity and the achievement, and then we can do some MMCs, the different type of the rotation. So in the digital occlusion setup, not only in the compensity, and then before the surgery we can do a lot of preparation. After a fully prepared in your design, and you can shorten your time once you really do the operation, not to spend too much time in your OP, and it can reduce the time loss and shorten the timeline. And then you can design the digital occlusal setup first, not only by a single stand be used. You can, depending on what is your style to deliver, maybe it's the maxillary first, or you can design it got mandible first. And the two standing modality is now currently be very frequently be used in our daily the OGS procedures. So once the virtual surgery is already be performed or be prepared, a lot of advantagements can come up and could be happen in your real practice. So once you have a very good preoperative design, you could know how much is the real advancement and how is the row rotation or what is the yaw rotation. Once you do the level 1 osteotomy, and you can know how is the left side or the right side advancement. This is the distance you can do the measure once you do the surgery. So it could offer you a very precise information once you do the surgery. And then once you look at the level 1 area, the row rotation is be designed as well. So you can use in the ruler to know how is the left side intrusions, how is the right side extrusion, and have a very precise result as well. And then once turned into the mandible surgery and the bilateral splitting sagittal osteotomy, how much is the volume setback could be preliminarily be checked, so you can measure is the final result or the outcome is matched and to your original the plan as well. So all the information currently now is all available in our daily practice to do the orthodontic surgery. And this slide is to tell you where is the inferior alveolar nerve's location, and once we do the splitting of the osteotomy in the mandible, we should take care of our osteotomy line and the vector. So the IAN, I think in the preoperatively, you should pay attention to know is the location. It probably located in the lateral, in the central, or in the medial. And you have to know the IAN's outlook. Maybe in the last stage, you want to perform the genioplasty. So what different style of the cutting you want to deliver. So you have based on your acknowledgement to know the inferior alveolar nerve's the outlet, and then will not damage to the nerve. So all the information is already could be obtained before the surgery. So before the surgery and the post-op the surgery, before and the post-op. So all this kind of bony relationship you can do the simulated in before the surgery. So we can check on a small video. So in this video, we do the row rotation first, and then we set back the mandible. And once we set back the mandible, and then we correct the overbite, and now we can do the yaw rotations to correct the midline. And we do a little bit clockwise pitch rotation to have a better occlusal plane and to match a good A point and the B point relationship, and the final to confirm the occlusions. Okay, so all this kind of information is a good practice to reflect the image is a good helper and useful. Okay, so as for Cleft babies, when he was born, you can show a completed lip and the palatal defect. So after patient received the alveolar bone grafting, and we can deliver good orthodontic surgery to correct her bony and the external facial appearance. So in our center, I think the being with the Cleft patients, always we can accompany with him or her and with all her parents with almost 18 years since born to adult time. For example, we can deliver a good lip repair, and we can repair the palate defect as well. And after on, finally, the patient can come to achieve to correct the final occlusal deformity, and the orthodontic surgery or the finals, the rhinoplasty could be delivered to her to have a better aesthetic outcome. So the take-home message is the hard tissue and the soft tissue should be evaluated by different imaging modality based on what is the surgical procedure you choose at what the age the patient want to receive the surgery. And the last one is the soft tissue is possibly be predicted as the hard tissues move. I think you can easily to translate it how is the final appearance could be changed preoperatively, and the well education is very important. So thank you for your attention.